Good evening, everyone. This is Janine Zitianellis. I'm a PhD researcher at the Monarch Business School of Switzerland, and I will be taking you through our research within clinical trials, how we're integrating health behavior and AI and ML theories to improve the trial recruitment process. To guide this presentation, I will be taking you through the research problem we've identified. And before I move on today, I would like to position this research in where it sits within the clinical trial space. When patients or candidates get recruited for a study or a trial, we normally run them through a pre-screening phase where a clinical trial recruiter will contact a potential candidate and take them through a pre-screening process. If the candidate is successful, they will then be referred to a site where a further screening process will continue for any suitable candidates for the trial. So the research is positioned in post successful pre-screening, but between where a patient gets referred to a site. From there, what did we try and improve? We wanted to improve the initial pre-screening or patient recruitment phase. How did we try and improve that? We leveraged AI, or what we would see now as natural language processing, and we leveraged predictive modeling. We integrated these two worlds with health behavior models or theories. We then, from these models, the integrated models, we then dug into SHAP analysis to actually determine of these findings, behavior findings of patients, what really mattered and determined whether a patient would screen successfully at a site. Finally, we determine why does this matter? Why is this model any different from existing pre-screening models or recruitment models, and what impact can it make to the real world? The problem currently, most recent stats reported by Antidote still reports that over 80% of clinical trials face delays and or are delayed due to recruitment issues. Delays are costly. It can cost sponsors up to 600,000 to 8 million per day in a delay in a trial or product reaching the market. Screen failures can on average cost a sponsor roughly $1,200 per failure. The bottom line is delays increase cost. It increases risk. It also can result in unpowered results and unequal health outcomes. Our traditional screening methods often filter patients or potential candidates, but does not necessarily understand why they do not qualify or why they choose not to continue or take part in clinical trials. Before we continue on this slide, I would like to draw on a quote that really anchored the research for me. The quote is from Dr. Bessels van der Kolk, which states, "The way medicine approaches human suffering has always been determined by the technology available at any given time." This is quite clear in how AI positively impacts across clinical trials. There's been several reports, several research papers on how AI improves drug discovery, how AI improves trial supply chains, but none of which really talks to or takes on patient motivation. Hence, from there, we went into establishing a research question, and we looked into several health behavior theories. We then established chose the health belief model. And we asked the question of how can integrating the health belief model constructs with AI and ML models enhance the prediction of successful clinical trial site screening. Once we integrated these models properly, we went on exploring which behavioral or contextual factors predicted site screening success. Subsequently, we then moved on to how does the reach of the patient, when the site has to reach out to this patient to screen him, what is the impact of that time passing? Does it even impact the patient progressing through? to successful randomization. To dig into the HPM for a moment. The HPM includes constructs like perceived barriers, benefits, severity, and cues to action. These we used in the screening questions and responses for interpretability. The HPM constructs, like I've mentioned, consists of severity, susceptibility, barriers, and benefits. Severity refers to the person's belief about how serious or severe or serious the disease is, or how serious they have it. The susceptibility refers to what are their chances of getting a certain condition. This is quite highly significant in where family members, a mom or dad, has a certain disease, and the individual or the patient feels that they are at risk of obtaining the disease. Barriers refers to the individual's perception of any obstacles that could interfere with them participating in a clinical trial. This could be transport, childcare, the period of the trial, the invasiveness of the trial. Then, out of all of this, if they do participate in the clinical trial, how significant are the benefits? And does these benefits, the treatment, lower their risk or exceed the amount of traveling that they need to do, or outweigh the invasiveness of the procedure? To take a look of how did we use our screening questions and their responses and take these and map it to a construct, an abstract construct as severity, susceptibility, or barriers, we employed NLP methods, name entity recognition, and we mapped what was identified through an ensemble label, diagnosis, symptoms, and treatments to these abstract constructs of the HPM. Symptoms linked to perceived severity and susceptibility. Treatments indicated a perceived benefit that the potential patient or patient referral would observe. And then barriers were linked to any practical, emotional, or issues related to the trial burden. So how did we move on from there? What did we do after we mapped the pre-screening questions to our constructs, and how did we then go and predict whether a patient will move through to a successful site screening? We included these behavioral variables or HPM constructs, and we created an XGBoost model. And we observed that incorporating or including the behavioral variables did improve the interpretability and the performance of our model. Some insights into how we trained our model: we used a training split, a 70-30 training split with a 5-fold cross-validation and early stopping mechanism. The model achieved an overall accuracy of 67% with a area under the curve of 74%, and we observed a balanced outcome across the classes. We did see disease variation, specifically in sensitivity or specificity. Overall, our main top predictors, which I will discuss in a bit more detail further on, was barriers, disease classification, or mostly known or commonly known as mesh headings, and overall social vulnerability. We interrogated or needed to understand how did the model make the decisions it made, or how did it decide what would lead to screening success. We did this through feature importance and SHAP values. We analyzed our SHAP values, both of which indicated perceived barriers, disease classification or mesh headings, and social vulnerability are the top predictors that significantly indicates whether a patient will successfully pass the site screening phase. The SHAP values also indicated a heterogeneous distribution across barriers and social factors for these patients. While susceptibility, severity, and benefit showed minor contributions, they were still statistically significant. Minority indicator had a minimal predictive effect. We further needed to understand how do these behavioral constructs or behavioral mechanisms vary across diseases. We wanted to understand the key features across the disease by applying a hierarchical clustering. The heat map showed the average values for classifying diseases and behavioral features, allowing us to group disease types with similar referral patterns and features. We observed two distinct groups. Certain diseases classified together based on behavior, severity, and vulnerability, while others classified together based on benefits and susceptibility. For example, we have observed musculoskeletal, neurogenital, and psychological and bacterial infections clustered together due to these shared influences on perceived barriers and severity. In contrast, female urogenital diseases and congenital diseases appeared more isolated, suggesting unique factors. Recruitment strategies should consider these condition-specific dynamics rather than a one-size-fits-all approach, enhancing the understanding of patients' responses. The problem we faced is that static classifiers like XGBoost effectively assesses initial referral likelihood, but often overlook the critical time factor of a site reaching out to a patient. The delay in site contact could be for various reasons: unavailability of patients or sites experiencing capacity challenges, operational challenges, and so forth. To address this, we incorporated a Kaplan-Meier survival analysis into our existing model and adjusted our static probabilities. From there, we observed that there's a critical contact or period in which a patient needs to be reached or a referral needs to be contacted. By adjusting the probability of a patient being successfully contacted with the static probability of them passing the phone screen, we realized that we overestimated the probability of a patient successfully passing the site screening by over 56%. A key insight was that we normally have a window of roughly 11 days to successfully reach a patient and to make full or ensure that the patient successfully moves through the funnel. Integrating the survival probabilities enabled time-sensitive prioritizations. We also observed that these adjustments varied across diseases. Within certain diseases, it was more important, or it's of more a time factor importance to reach out to the patient very quickly, as opposed to others. An example of this was in musculoskeletal, digestive, and endocrine referrals declined rapidly due to the complexity of the protocol or the high patient burden. If we do not factor in this time frame, we risk losing most viable leads. Integrating survival probabilities enables time-sensitive prioritization, disease-specific logic, and real-time outreach, transforming the model into a decision support tool that aligns prediction with site capacity. How did we ensure the ethical application and integration of AI into our referral models? We ensured by stratifying the sample across disease classification and minority group. We also validated that the performance across our social vulnerable subgroups was stable, indicating equitable prediction for structurally disadvantaged patients. We assessed our predictions to make sure that there was no significant misclassification in symmetry and that the model did not favor one class over the other. The model validated the most influential predictors, perceived barriers, disease classification, and overall vulnerability are all conceptually grounded in the health belief model. Overall, we ensured that this was not only a high-performing model, but that our model was explainable and grounded in behavioral theory and equity principles. What was the end result of our research? We had a behavior-driven or a behavior-first AI pipeline. It enhanced our knowledge of patients' beliefs and perception, and how this impacts trial participation. We allowed for real-time recruitment strategy adaptation by incorporating the Kaplan-Meier's. Including patients' beliefs and perceptions allowed us a adjustment across diseases. By incorporating the social vulnerability index and minority indicators, we aligned with regulatory frameworks, all of which allows us to enhance patient recruitment and reduce burden on sites. The research has several assumptions and limitations that should be made clear. In any studies where we observed missing data or missing protocol information, we had to remove these observations. Secondly, we did observe class imbalance in certain studies, where the number of failed screening or site screenings outweighed the number of successful screening. In certain diseases, we had small sample sizes, limiting the generalizability of the model. The biggest and most significant impact was language ambiguity, where the NLP struggled to deal with ambiguous responses such from patients as unsure or inconsistent phrasing in pre-screening questions, and we were not able to clearly extract health belief constructs using the name entity recognition. Other than that, the LLM introduces large bias from pre-training data. And finally, the diagnosis given on the patient referral was assumed to be accurate and correct. These were mostly diagnoses or diseases, and we were not able at this stage to verify the validity of the disease via medical records or a clinician. Therefore, the assumption is the disease is, or the patient's self-reported condition is correct. Finally, in summary, clinical trial recruitment remains hindered by behavioral and contextual blind spots. To be effective in recruitment frameworks, the frameworks must reflect an individual's belief, community norms, and contextual realities. By integrating behavioral theory with AI and ML, it can improve the clinical trial recruitment process by predicting the outcomes and revealing the psychological and social factors influencing these outcomes. Behavioral constructs like perceived barriers or vulnerability are key early predictors of referral success. Embedding behavioral constructs into AI and ML models enables behaviorally informed recruitment strategies. Survival analysis further enhances the AI and ML by highlighting timing sensitivity and real-world operational windows. Thus, a holistic, more theory-informed and a data-driven approach can reduce burden on the patients and the research sites alike. I would like to extend my special thanks to Dr. Henderson, the Dean of the school at Monarch Business School, as well as the team members from SubjectWell for their valuable contributions. A special shout out and acknowledgement extended to Tommy Habib for his valuable contributions to this research by applying the health belief model through the natural language processing. His expertise in the named entity recognition and large language models provided important links between theory and practice. My gratitude is also expressed to Becky Capps and Dr. Matthias Ruiz at the SubjectWell team for their support in advancing patient experience in clinical trials. Thank you.